Sorry, technical difficulties. We're not all as versed in Zoom as Rabbi Fell is.
Sorry. Oh, people are.
Okay, you're all set. It says recording.
Yep.
Okay, perfect. All right, go ahead, Sharon.
Okay, so thank you all for coming tonight. I'm very happy to introduce Dr. Michael Fine, guru to everything COVID. And we're very, very lucky to have you as our own personal COVID information person. So without further ado, take it away.
Thank you. Thank you for that wonderful introduction. It's nice to be with everyone tonight. It's a way to get warmed up a little bit, I guess. And I'm going to speak relatively briefly and then let people ask questions. Things are continuing to get worse, but they're in terms of the spread of the infection, but there's light at the end of the tunnel in terms of vaccines. So we have some good vaccine news, but we're looking at a tough 6 to 12 weeks, very tough 6 to 12 weeks. In terms of numbers around the nation, we now have more than 14 million people who have been infected, and 277,000 deaths. We had a very unfortunate 24 hours of 2,700 deaths in 24 hours in Rhode Island. We are really seeing the equivalent of about 2,000 new cases a day when you correct for testing. If you were testing 20,000 people a day, we're actually testing now about 10,000 people a day. Not as many as we have before, but we think there's 1,500 to 2,000 new cases a day, which is unfortunately where we thought we would be. We have over 400 people hospitalized from COVID. We have one of the auxiliary hospitals now open with 6 people in it, but it looks like we're seeing 40 or 50 new people come to the hospital pretty much every day. Very unfortunately, we had 11 deaths in the last 24 hours for 1,391 total deaths in Rhode Island. We expect 10 to 20 deaths a day for the next few weeks, maybe more. And I think we are looking, unfortunately, at a very difficult December. I did some quick calculations today, and I fear that we're looking at somewhere between 350 and 800 or 900 deaths in December alone. So it's going to be a tough month, and I will continue to urge people to stay home as much as you can, and just not interact with other people. That's how we break the chain of transmission, which is what we really need to do. One piece of good news is what's called the case fatality rate. The percent of people who get COVID-19 and die from it has dropped really almost by 2/3. It was 2.3% over the last 8 or 9 months, but was only 0.7% in November. So people who get COVID are way less likely to die of it, even though more people are dying, and that's because more people are getting it. But people are much more effective at treating it. There is now some medicine that helps people if they are at high risk, if they can get the medicine early. So if you should go positive and you're over 60 or have underlying chronic disease, please call your doctor and see if you qualify for one of these new monoclonal antibodies, which appear to help people recover. Now, the other good news is we now have 2 new vaccines, a new kind of vaccine that have finished their phase 3 trials and have shown very good efficacy. They're 94 to 95% effective, which makes them one of the most effective vaccines we have. And they are going to the FDA for what's called an emergency use authorization. The first from Pfizer is going on December 10th. The second from Moderna is going on December 17th. What's expected is they will get the emergency use authorization. They have to go through a evaluation both by the Advisory Committee on Immunization Practices of the CDC, which will happen a day or two later. So we expect vaccine to be released sometime about December 14th or 15th, and to arrive for the first time by about December 20th. We expect we will see between 10 and 60,000 people's worth of doses arrive in Rhode Island in December, and about 60,000 doses arrive in January. Now, that's not enough for the whole population by any means. So there's been a process to prioritize who will get vaccine first, and it looks like we will be prioritizing frontline healthcare workers, nursing home residents and staff, home health workers and EMTs. They are likely to get it between December and January. And then we will likely move to people over 65, people with high-risk medical conditions, and essential workers in the months after that. My guess is it will take till May or June before we get the adult population fully immunized, those who want to be immunized. Children do not have, the vaccine hasn't been tested on children yet, so we don't know when children will get vaccinated, but I'm guessing it won't be till late in the summer or the fall because of the time and energy it's going to take to get the vaccines administered. What everybody knows about these first two vaccines, the most important thing to know is that the site reactions, the immediate reactions people get after they get a shot are a little more intense than you get if you get the flu vaccine, a little more pain where you got the shot, a little more fever, a little more, feeling tired, so that most people are planning, we believe about 40% of people have a reaction like that. And so we are planning around that reaction so that people who get the shot can be out of work for a day or two after the shot before they go back to work. And, these are pretty normal reactions when people get an effective vaccine. So we're not freaked out by it, but it may make it a little more controversial because nobody likes any discomfort in the United States anymore. So that's basically where we are. We're thinking that the population gets vaccinated by May or June. If enough people want to get vaccinated, that will help us get the pandemic stopped. But the light at the end of the tunnel looks like it's in July or August. Assuming we can convince people to get vaccinated, the real roadblock is that about 40% of people are saying that they're not going to be in a hurry to get a vaccine. We believe now about 20% of the population has been infected already. My guess is by March or April, we'll see 40 to 50% of the population having been infected, because we just won't have enough vaccine around quickly enough to stop the spread of the infection. And my second guess is that we will see the pattern of last spring repeat itself, so that by the end of May and the beginning of June, I think we will see that the spread of disease dry up a little bit. Not so much because of the vaccine, though that will help, but also because of some environmental factor that I don't think we entirely understand. So that's most of what I have to say. Why don't I shut up and let people ask questions or make comments?
Marilyn was wondering about the side effects for seniors. She's been reading reports about side effects and she's nervous about that.
Well, we believe at the moment that seniors are no different from younger people vis-a-vis side effects, and those side effects are, in general, sight tenderness, fever and chills, headaches, and tiredness in about 40% of the population. Most of those are usually blunted if you take a little Tylenol after you've had the shot. The vaccine has been studied in people up to 75 at least, and I think in some people older than that. It hasn't been specifically studied in nursing homes, but I think that's going to happen fairly soon because nursing home residents and staff are people who are prioritized for vaccination in Rhode Island. Next question.
Beth, you want to unmute and ask your question?
Yeah, so I had a question. I was reading that the RNA vaccines from Moderna and Pfizer
Yep.
didn't actually measure if people got infected, but that they measured because they prevent illness, not infection, that they actually measured whether or not people got sick. And I just wondered if there was any testing done, like you know, to see like if people had low viral loads of these of SARS-CoV-2, you know, that didn't, even if they didn't develop illness. Did anyone look at that? And would people with those vaccines still be able to infect others?
I don't know the answer to that. The results of the phase two trials are made public at the time of the FDA review.
Okay.
So I don't think we'll see that data until December 10th. One of our challenges is that we don't have a good test for active infection. So all our tests are sort of secondary tests. We test for evidence of vaccine breakdown products. It's what the PCR test does. Or we test for other antigens, other pieces of the virus. But we don't have a test that tells us either that someone is actively infected and infectious, and we don't have a good test that tells us that someone is not infected, but only that we can't find evidence of the virus. So you ask a brilliant question, which I unfortunately have no answer.
Oh, that's interesting. I didn't know that we don't even see all the data until December. So that's interesting too. Thank you.
But we'll all keep our eyes on that question. You know, the process is that after each vaccine receives emergency use authorization, it is then reviewed a second time a day later by the ACIP, the Advisory Committee on Immunization Practices. And they make specific suggestions about its application to the population based on the data that's provided by the developer. So I think we will learn a whole lot more in the process as they review things with a fine-tooth comb. The thing that I keep counseling people to remember is that the difference between a phase 3 trial and phase 4, the post-marketing phase, is actually quite substantial. You know, effectively, a phase 3 trial means that this drug has been tested, or this vaccine has been tested in 15 to 22 or 23,000 people. It doesn't mean it's been tested in the entire universe. And so side effects and complications that occur relatively rarely, with an incidence of less than 1 in 22,000 or so, may not be discovered in the phase 3 trial. So it will not surprise me one bit if in the post-marketing experience, as we then apply the vaccine to, hundreds of thousands and then hundreds of millions of people, we may find, what are thought to be potential complications. And it shouldn't upset anyone if in that period, the FDA imposes a short pause while a reported potential side effect is more carefully studied. This is the normal process of vaccine or drug introduction, and is a healthy part of scientific inquiry and the safety evaluation. And that's one of the good things about the notion that there are actually 13 vaccines that got to the point of getting phase 3 trials. There are 11 of those trials either not yet started or ongoing. I believe 4 or 5, or maybe 2 or 3 in the United States altogether yet to do. So there will be other vaccines, and they will have other side effect profiles and other rates of efficacy. But having multiple options is a good thing, because it would not surprise me one iota if we lose 1 or 2 of these vaccines along the way.
Deb, you want to unmute and ask your question? Not sure what you mean by it. All right. Deb?
Oh, sorry. I was just trying to unmute myself. Okay. So what I was wondering is, I'm trying to think how to phrase this. Because this is an RNA vaccine, I'm wondering where the body is. I mean, it works differently than, let's say, a flu vaccine. Is there information on like autoimmune side effects from this vaccine?
I mean, the information is the information that's going to be presented to the FDA a week from tomorrow.
Okay.
So we'll see it then. But what the company reports is that these side effects are, not overwhelming, but present in 40% of the population. However, that's with a relatively short period of post-administration observation. So, we're going to learn more over time as we have more time to observe and as many more people get vaccinated. But I'll bet $1, maybe even $1.50, that we will see some autoimmune problems that happen, just as we will see worse autoimmune problems in people who have been infected by the virus.
Okay. So as far as you're concerned, would somebody who has either a primary immune issue or an autoimmune issue be concerned about the vaccine?
Well, I think it's worth that person discussing it with their own physician. This stuff is all unpredictable.
Okay.
And one of the paradoxes of vaccine development is that when you have a vaccine that works really well, there's usually an autoimmune crossover and some problems because it works so darn well. It's done a good job. It has incited the production of antibody, but our antibodies aren't any smarter than our politics, and they sometimes overdo it.
Okay.
So, a vaccine that doesn't work very well is likely to have very little autoimmune consequence. A vaccine that works well, unfortunately, is likely to have substantial vaccine or antibody or autoimmune potential risks.
Okay. And can I ask one follow-up question? And that is, if somebody tolerates the flu vaccine well, although the mechanism is, I understand, different, okay, would somebody and had those issues, is there any prediction regarding this vaccine?
I don't think so. And I don't think there's likely to be. Each substance you introduce into the body, trying to trigger the immune system, If it does it effectively, will have its own profile of
Okay.
activity.
All
So
right.
it's pretty unpredictable and also variable from person to person.
All right, thank you.
I'm curious for people who've had COVID, do you think that they will need to get the vaccine?
You have asked the great question. At the moment, CDC is saying, yes, vaccinate everybody. Though, again, that won't, that's what the draft, as I understand it, says. That won't be made certain until FDA issues an emergency youth authorization and ACIP makes recommendations based on that. But the rough thinking is that immunity to COVID-19 appears to last sometimes as little as a month when it's naturally occurring after you've had the disease. And it appears that immunity induced by the vaccine lasts 3 months or more. So I think people are thinking, let's give people the best immunity we can. And there's no real contraindication to getting people vaccinated. So they're saying, let's vaccinate everybody.
Okay.
Next question.
Marilyn was wondering, since the vaccine needs to be at such low temperatures, do they have what they need to get that here, to store it and everything?
They're putting it in place, and that's for one of them, the Pfizer vaccine, but not for Moderna. And even for the Pfizer vaccine, the low temperatures have to do with shipping and storage. But what I understand now is that once the vaccine is thawed from the deep freeze, I think it's 90 degrees below zero. But once it's thawed from the deep freeze, then it will last in the refrigerator for 5 days. So that, it's just keeping it that's the problem, not administering it in that way. Though I'm also told that it's still a tricky vaccine to administer, that it requires some mixing. The Moderna vaccine is supposed to be easier, and some of the vaccines that are coming are supposed to be easier yet. So that's why I say, we'll start with the ones we get, but it would not surprise me at all if in a few months we have pivoted and are using another vaccine. This is just the first vaccine, not the one that I think we may live with forever and ever, which is really, what happened with polio. We started with one vaccine and over years have pivoted to fairly substantially different vaccines.
Anyone else have questions?
Is one dose is not sufficient. Is that correct?
And for the Pfizer vaccine, the second dose is administered after 21 days. And for the Moderna, it's after 28 days. You will see different schedules occurring for each of the different vaccines as time goes by.
Okay.
And I'm, you may have read something about the AstraZeneca vaccine, which has also finished a clinical trial. I think most phase 3 trial, most of us, there was some funkiness in the way the trial happened. So I'm kind of expecting they're going to be required to repeat the trial and change it a little bit. And based on the results I've seen so far, it wouldn't surprise me if that one doesn't end up being a 3-dose vaccine, not a 2-dose vaccine, but time will tell.
But do you need to, once you have these doses, whether it's 1 or 2 or 3, that's not a lifelong cure-all?
We don't know.
Okay.
This is new to us. And, I can't predict that piece of the future, nor many other pieces of the future either. I think time will tell as this evolves. and we follow the ecology of its circulation. You know, it may be that we need to get revaccinated. It may be that it's the kind of virus like other coronaviruses that circulates at low level and helps people maintain their immunity because they get recurrently exposed. We'll see.
Okay. Time will tell.
Beth?
Yeah, I was listening to a news report about this, and I heard that there's going to be one federal database keeping track of who, like, because it's so complicated that people need these multiple doses, keeping track of what vaccine you received and when you're due for your next dose. And this was actually, I think the New York Times Daily that reported on this. And I was just curious if people people who work in medicine have heard anything about this and how this kind of national database would work.
I have not, but it actually begins to address a very central concern I have about us trying to vaccinate a population in a nation without a healthcare system.
Yeah.
Because we have no way to figure out who needs the vaccine, who has had it, who hasn't had it, and how to make sure that we, gently remind the people who haven't had it till they get it done. We do not have any kind of organized system. And, if they start with that, it's better than what we got. But boy, do we need a lot more if we're going to if we're going to beat this thing and then beat the next one. Because let me tell you, and I've said this before, this is a cold virus. This is nothing compared to, what we may run into in the course of the next 10, 15, or 25 years. So we desperately need these kinds of systems, just like we desperately need to learn that that everybody needs safe and healthy housing, because if you try to, house people jammed together, they will get sick. And we also need some way for people who have to go to work every day and work in factories, to have the same chance that people who work, from their houses on Zoom, to stay home if we're going to interrupt the transmission of a pandemic.
Okay. Deb was asking how the AstraZeneca vaccine works, but do you know? I mean, there's so many different ones. Do you know how they all?
I haven't looked at its mechanism, but it's supposed to be sort of more traditional.
That's what I thought. That's why I asked, because I thought it was different than the ones that Moderna and Pfizer are doing.
Right. As I understand it, it's not an mRNA vaccine. And so it will have a different mechanism of action. I think we'll wait and see how this mRNA approach works. I'm a little troubled that we have been subjected to battling press releases from vaccine companies as soon as they finish their clinical trial, their phase 3 trial. I would much prefer that this happen in a way that's confined to the scientific community. They didn't ask me first, nor are they going to, but we've got a lot of sorting out of what the public thinks, because the vaccine manufacturers were trying to, in a certain way, stampede the FDA and the CDC in their own interest, which is not a good thing. But time will tell, and we'll get more precise descriptions of vaccines as they go for FDA approval. Like I said, I think what's going to happen with AstraZeneca is that it's going to be required to repeat its phase 3 trials and do it with 1, 2, or 3 new arms. But again, let's see what FDA says and what they decide to do.
I just had another question also. Do you know if they're still is plasma still a treatment if people have had it? Are they still looking for donors, or are they moved on to other treatments?
I believe they have mostly moved on to other treatments. I don't believe that that plasma has been shown to be effective, as it rarely is for these kinds of infectious diseases. My profession loves to try it, but it almost never works.
Anyone else have questions? Anyone? Last chance? All right.
Thank you all.
Thank you so much, Dr. Fine. We really, really appreciate you joining us and giving us an update. It's really helpful.
My pleasure and honor. Be safe and stay warm and try to not hang out with other people. It's not going to be forever. I hate the mask and I hate the social distancing, but I think it's the way we protect each other. Thank you all. Take care.
Thank you. Have a good night, everybody.